Good afternoon, everyone. Welcome to our March 28th meeting. I would just like to welcome everybody. I would like to again remind everyone, if you have a cell phone, if you put it to non-audible function, that would be beneficial. And again, our meetings are web streamed and televised. We have a lot of work to do this evening. We will begin today with our Board of Health meeting, and following that, we will move into council. I would suggest that we get to the Board of Health meeting. After that, I would like to then go to the council agenda and get right to staff reports if we have time before we break prior to our 5 o'clock. Regardless, at 5 o'clock, we have some presentations, followed then by our public meeting. There are 5 items under our public meeting, as you are aware. I would ask council, maybe let's do it through a show of hands, if we could move the closed session, which is at the end of the council agenda, if we could move that up to take place right after the public meetings. I don't think it'll be a long. Could I have a show of hands that we could move that? That way, if staff's here, they won't have to wait about 3 hours to get to that. Thank you. So I will move the closed session up just after I close the public meeting, and then, of course, we'll go right back to the agenda of council. I think that's all we have. There was one addition to the agenda that you were made aware of, and it is the cancellation refund, et cetera, of taxes, and that will become item 5E under the public meeting. That's the motion when we get to it. Yes, I'll just set that aside. Okay. Thank you. So let's go to our agenda for the Board of Health. And welcome everyone. Dr. Locke, welcome. Good to see you here, sir. Are there any disclosure of pecuniary interest to declare? Our first order of business then is the adoption correction of the Board of Health meeting minutes. There are 2 before us. First of all, our last meeting of November the 22nd, 2016. The minutes of that meeting are printed on page 5, and then right behind them are the budget minutes from our Board of Health session during our county budget session week of January 24, 25, 27, and 29. Is there anything there that should be brought to the board's attention? Hearing none, I'll declare those as adopted. Now we'll go to staff reports. Marlene, and I must make a comment and say, I'm just wondering, did this board do something to upset you and Susan? Like, I'm just not sure. Perhaps, is everything okay?
Thank you, Mr. Mayor. No, nothing to offend us. Just lots of activity from the provincial level that we need to update the board and get direction on. Thank you.
Okay, I feel better, and I would say that the staff has been extremely busy. Is that a fair statement?
That would be a fair statement.
That'd be a fair statement. First item is the Acting Medical Officer of Health update, and you'll find that on page 12. Dr. Locke, please.
Yes, good evening, everyone. Just a little update on the current situation medically. Locally, as you see from the report here, we had some mixed outbreaks in the long-term care institutions, but currently I've checked, and we currently have no influenza A in the community long-term care institutions at the present time. We had a single case in Brant of pertussis. Again, this is something that we've been seeing through the province in the last few months, increases in whooping cough, but I have no further news on that one. As far as the influenza is concerned this year, we've had predominantly influenza A variety been circulating, which is the H3N2 variety. This is the one that gives most problem with regards to long-term effects and also with regards to the elderly. It gives a more morbidity and increased disease status for that. The proportion of outpatient visits, as an example, in the United States was 5.2, and that was about the same here in Canada as well. I reported to the board earlier last year that the effectiveness of the vaccine that we had this year was thought at that point in time not to be very effective, but in actual fact the strain that came through was very susceptible to this particular vaccine. So in the United States they had about 43% effectiveness, and in Canada here we had about 42% effectiveness. That may sound low, but in general terms that's quite a good response. We also had some strains of the pandemic flu, the H1N1, circulating as well, but both of these were well matched to the vaccine as well as the B strain that we're now seeing a few sporadic cases coming through. Classically, the B strain comes through after the A strain, if that is the predominant strain coming through. Now, according to the CDC, there's been more than 75 cases of mumps throughout the country, and we have seen that here in Canada as well. And we've had, again, sporadic outbreaks. This has been in the media quite a lot recently, as you may have noticed, but it needs to be taken into perspective because mumps is endemic in North America, both in the United States and Canada. So we will see these things coming through. And looking at the statistics and the number of cases that we have, it's really not extraordinary, but it has hit a few of small groups and has got a lot of media attention because of that. The fentanyl initiative, we're still pursuing that at the Health Unit, and I must say that that's gaining a lot of traction throughout the province as well as throughout the country, so we're very pleased to be partnering with several organizations locally on pursuing that initiative. In British Columbia, we had over 200 cases of a gastrointestinal illness, and that was due to consumption of some roy oysters that were coming from British Columbia area. At the time that I wrote this report, that outbreak was yet to peak, and we were still seeing cases from exported oysters into Ontario and other provinces. The rabies issue continues. We did have a rabid cat in Hamilton a month or two ago, and that caused a bit of a stir because there was some human contact with that animal. It was mainly in Hamilton, and Hamilton Public Health did a door-to-door campaign in the area where the cat was thought to be roaming. We've had also a suspected case of a horse here in Haldimand last week, but unfortunately after they took samples of the brain and sent away, the samples were inadequate for proving that this was in fact rabies. But the vet thought that that definitely this might have been a rabid horse. So that's a bit of a concern. So generally, we've had, at the moment, I think 239 cases all told of raccoon rabies circulating, and that doesn't seem to be abating at the moment. We did not see much about this, but the Chief Medical Officer of Health put out an alert about 3-4 weeks ago related to a thing called Sol virus. and that's Seoul, as in Korea. This is a hemorrhagic virus. In other words, it causes hemorrhagic disease, leaking of the blood through the blood vessels into the vital organs, and can cause a chronic renal disease issue. The source of this is actually coming from rats and rats' fecal material and urine. And anyone coming into contact with that have the chance of getting this particular virus. We did have, because of that, there were some tests conducted in ratteries through Ontario, and we did have a few positive serology cases coming from workers that were working in the ratteries there. So there's no transmission from human to human of this disease. Generally, it's close contact with, as I say, fecal material or waste products of rodents. And I've heard nothing more about that, so I think that's probably well controlled. That's the end of my report, Mr. Chair. I'd be glad to answer any questions.
Thank you very much, Doctor, and we appreciate your report. Are there questions on his report? Mr. Oliver?
Thank you, Mr. Chairman. Do you want us to stand when we're asking questions?
Not for the Board of Health, no.
Thank you. Doctor, thanks for your report. Under the influenza section, I had read those statistics in terms of the effectiveness at 42% in Canada, and you described that as relatively good. I mean, I thought that wasn't very good, but that shows what I know. What would you say statistically across Ontario? How much lower than that would it be before the health profession across the province says, boy, this vaccine didn't work? I mean, if 42 is good, what do we consider a poor match?
Generally, if we get a mismatch, through you, Mr. Chair, generally if we get a mismatch of vaccine, those numbers are usually much lower than that. Yes, and and you get the associated morbidity and pneumonia and respiratory illnesses among the elderly and the young. So a real mismatch would be much lower than that.
Further questions? Mr. Columbus?
Thank you, Mr. Chairman. Dr. Locke, I noticed that on TV the other day that there was indication that flesh-eating disease is on the rise, and it's caused by the joining of two different illnesses. Can you comment on that?
I think you're probably talking about eye gas, which is a group A streptococcus. It's a particular strain of group A strep that causes this particular problem. So you know yourself that strep throats and things are extremely common. And it seems that people that succumb to this particular illness, if they get a cellulitis which goes on to the flesh-eating disease, it's necrotizing cellulitis, then it's because their immune systems are somewhat compromised as well, for whatever reason. But it's a fairly rare, although we're seeing more of it, I think that's because it's being diagnosed earlier and is being seen more and reported more. But it's been around, and I think, unfortunately, will continue to be around.
So is it contagious, or?
It's contagious in as much as if we have a positive in the health unit, we're advised by the laboratories if they have a positive strep group A, and we have 24 hours to follow that up according to the ministry guidelines, which we do. So if we find that group A strep is in a home, I have to make a decision as to whether we're going to then prophylax the rest of the people in that family or in close proximity with that case. Yes, it is infectious, but not everyone that gets group A strep is going to come down with necrotizing disease.
Thank you.
Mr. Sonnenberg, please.
Mr. Chairman, Dr. Locke, occasionally we hear of, back to the rabies issue, anti-rabies vaccine being dropped from the air. Is this an ongoing, regular thing, or do they just do that when there's an outbreak, or how regular is that method of anti-rabies?
Through you, Mr. Chair. It was very regular up until a couple of years ago when the Ministry of Natural Resources decided that they weren't going to do it. And we think that has a impact on the rabies that we're seeing now. They have now covered a very large area with a large, over 1.5 million doses of vaccine that they've dropped in the last, we'll say, year. But prior to that, they reduced that program, and so the vaccine drops and the baiting was not carried out. And we think that has had an influence on this current situation that we have now.
Do we know why they stopped the program? Too costly, or?
I can't comment on that. I don't know.
Thank you. Further? Resolution in front of me. Wells has moved. Mr. Columbus has seconded that the update from the acting medical officer of health be received with information. Any discussion, anything further? Those in favor? It's carried. Thank you. Page 13, staff report 17-02. This is the food insecurity report in Haldeman, Norfolk for 2016. Marlene, please.
Thank you, Mr. Mayor. I'd like to introduce Molly Campbell, one of the health unit's dietitians, and she will be presenting the report. This report is an update on the food insecurity for Haldeman, Norfolk in 2016, and we are also requesting that the Board of Health correspond to our respective ministries regarding the urgent need for income responses to food insecurity and supporting the establishment of a Social Assistant Research Commission. And with that, I'll turn it over to Molly.
Thanks. As Marlene said, my name is Molly, and I'm a registered dietitian at the Health Unit. Today I'm here to present the results from the 2016 Nutritious Food Basket Survey and to discuss current and future action in the area of food security and poverty. As you are aware, as a health aide, we are mandated to monitor the cost of healthy eating in our region, and we do this by collecting data using the Nutritious Food Basket tool. We then use these results to advocate for policies that address food insecurity. The results of the 2016 survey, which are presented on pages 1 and 2 of this report, show that the monthly cost of groceries for a reference family of 4 living in Haldeman and Norfolk is about $881. This represents a $9.49 increase from the 2015 results, or about a 20% increase over the past 5 years. As we can see, food costs continue to increase each year. However, this isn't the real reason a person may find themselves unable to afford food. Inadequate income is the root cause of food insecurity, and Table 1 on page 2 of your report helps to illustrate this. This is a simplified version of the chart comparing 2 families of 4, one with a median income and one living off of Ontario Works. You can see that after paying for rent and food, a family living on Ontario Works only has about $500 left at the end of the month. This illustrates why people are often forced to cut into their food budget to pay for other expenses such as utilities, clothing, personal care items, transportation, medical supplies, and childcare. Overall, this chart highlights that social assistance rates are not always in line with the cost of living. Now, looking at our current landscape, you'll note in the report on pages 3 and 4, they review different definitions of definitions of food security. But regardless of which definition you use, rates of food insecurity in Haldeman and Norfolk are just slightly lower than the provincial average, sitting around 11%, whereas the provincial average is just over 12%. You'll likely remember when we presented this last year, a report put out by Cancer Care Ontario stated that Haldimand and Norfolk had the highest rate of food insecurity in Ontario at 16.4%. And while we could hypothesize what factors may be contributing to this number, we needed more evidence to figure out what was happening. We couldn't determine an explanation for this rate, and after consulting with Cancer Care Ontario, it was determined that these were actually an error. Cancer Care Ontario has since removed the report from circulation until it's updated. Moving forward as a health unit, we will analyze the Canadian Community Health Survey data internally in order to consistently compare food security rates from year to year. Nevertheless, when people are living with food insecurity, we see a negative impact on their health, and this is why we need to do the advocacy and local work in this area. We know that adults who lack access to healthy food have poor physical and mental health. They're more likely to suffer from chronic conditions such as diabetes, high blood pressure, and anxiety. They then go on to use significantly more healthcare dollars than their food-secure counterparts. A wide range of actions are being taken at a local level. In terms of short-term relief, we have a number of emergency food programs in the 2 counties. The Health Unit and Church Out Serving collaborates on a Food in Haldimand and Food in Norfolk brochure in order to direct clients to these services. We also have a student nutrition program that provides free food to school-aged children. From a capacity building perspective, we have community gardens, kitchens, and plans for a community food hub through Church Out Serving. The Health Unit also offers a food skills program called You're the Chef. In terms of system redesign, we have the Poverty Action Partnership of Haldimand and Norfolk, which has representation from several community organizations, as well as counselor participation. They're looking at what research and evidence is related to poverty and how to best address these issues locally. We have also done advocacy work, for example, with the endorsement of the Ontario Society of Nutritional Professionals in Public Health position statement that the Board of Health endorsed last year. While so much good work is being done at a local level, we know that targeted and sustainable approaches require an income response, and this is primarily tackled at the provincial or federal level. Exciting things are happening in this area, including the Basic Income Pilot Project that received funding from the provincial government last year. As it will be an overhaul of the social assistance program, it has the potential to give people the money they need for basic needs. Currently, the government has finished their consultation period with the public and are announcing the next steps in April, including how to design, deliver, and evaluate the pilot, as well as which communities will be involved. While this is going on, as it takes time to research and implement, Bill 6 is another exciting initiative which calls for the establishment of a Social Assistance Research Commission. Currently, social assistance rates are not indexed to inflation or connected to cost of living. This group of experts and people with lived experience would use this evidence to inform decision-making on what social assistance rate should be. The bill has currently passed its second reading and is with the Standing Committee on Social Policy. Supporting this idea could potentially help those people living on social assistance while the Basic Income Guarantee pilot is going on. In conclusion, food security is a serious public health problem. While rising food costs are not ideal, it is inadequate income that is the root cause of food insecurity. Evidence supports income responses to address food insecurity, and while we should continue to support the great work that is being done in this area, such as the Basic Income Guarantee pilot project, and using evidence to inform social assistance rates. That concludes this presentation, and I would be happy to answer any questions at this time.
Very well done, Molly. Thank you very much. And I would say that you and Michelle have put together a very good report here. I'll open it for board members for questions. Any questions for Molly? Mr. Oliver, please.
Thank you, Mr. Chairman. Thank you, Molly, for your report. One of the local action items that you referred to is the Church Out Serving Group's plan to open the community food hub and kitchen down in the former LCBO plant facility in downtown Simcoe, which is a great project. I think council has been informed of it before. Do we have any sense within the health unit as to the timing on that? Is it going to happen this calendar year? Is it, or not, I guess? The sooner the better, obviously, but have you been given much sense of when they will be operational?
Through the chair, no, I don't have any more information. I know they have to go through a pretty extensive renovation process first.
Mr. Black?
Thank you, Chairman Luke, and through you to staff. And did I hear you mention anything about churches? I'm not sure if I heard you say anything about all the food that the churches raise around Norfolk County. I know our church just across the road here, they've got a big shopping cart at the back that's filled quite often, and they take that directly over to the caring cupboard who they praise all the it's not just the Anglican church here. I know that many churches produce a lot of food for the caring cupboards and Simcoe and other communities throughout Norfolk County. So I'm not sure if I heard you mention that or not, but I wonder if you could just speak to that a little.
Yes, through the chair. I did mention it under the short-term relief program, so it's definitely a big help in our community, the emergency supply food.
Thank you. Mr. Columbus?
Yes, Molly, how do you interpret the statement here, page 16 of the agenda, under the root cause of food insecurity? In 2014 in Ontario, the majority of food insecure households were working, 58.9%, but in low-paying or unstable jobs. Does that mean that 58.9% of the low-paying jobs, households, were affected, or is it all the households across Ontario?
Through the chair, that is 58.9% of the people living in food insecurity are working.
Substantial.
Mr. Height, please.
Thank you, Mr. Chair. Through you to staff, you mentioned programs like community gardens, and I'm wondering, do we have community gardens at our low-income housing buildings where people that live in those buildings can just walk down and do the backs?
Through the chair, I know of one in Dunnville that is a low-income housing. There's also a plan for one to be built at Hamilton Hall this summer. Church Out Serving is actually helping them facilitate that, so it will be right on site.
Okay, but so just one in Haldeman, Norfolk?
That I believe so, yes.
And so why wouldn't you want more of them, and what methods could you use to facilitate that? It's hard to grow a garden if you don't have a plot of land.
Through the chair to Councillor Height, your comment is correct. Some of it is about spacing, and we don't have them in our current housing. It's not part of the mandate or not something that's currently in place. It is something we can definitely take back and look at each of those housing, and is there an area or a space that we could actually work with the staff between housing and public health to see if that is a feasibility moving forward.
Okay, thank you.
Mr. Black?
Just in response to that, Council appointed me to the Poverty Action Partnership of Haldeman Norfolk Committee, and we have met down at Churches Out Serving. And during one of the meetings there, they did talk about the community gardens, and we do have one in Simcoe up at the industrial park at the north end of town. But they wanted to and thought about approaching Norfolk County to use, if you know where the old liquor store is, right across the road by the bridge there, that piece of land just right up front, and turn that into a community garden for the Churches Outgoing facility that will be have a culinary aspect to it and a kitchen. So they are looking at that. And I don't know if people know, but there's over 100 churches in Norfolk County, and there's some 20 in Simcoe alone. And if every one of those is bringing food and donating food, they really, I don't know how much they do, but it's tons of food that those churches bring in.
Anything further? Mr. Brunton has moved, Mr. Columbus has seconded that staff report 1702 be received as information and that the Board of Health correspond with the Premier of Ontario, Minister responsible for the Poverty Reduction Strategy, Minister of Community and Social Services, and the Minister of Health and Long-Term Care regarding the urgent need for income responses to food insecurity and supporting the establishment of a social assistance research commission. Any further debate, discussion? Hearing none, those in favor of this resolution, that is carried. Thank you very much. Let's go, please, to page 36. The subject of this is out-of-schedule rate for epidemiologist. Marlene, I'll turn it over to you, please.
Thank you, Mr. Mayor. I'm going to ask Susan Taylor to present the report.
Thank you, Mr. Chair and Board of Health. The first report that we have this afternoon is the out-of-schedule rate for the epidemiologist. One of the things that we routinely do within the health unit is when a position becomes available, we do review that position to see if it's meeting our current needs. So back in early February, the position of epidemiologist did become available, and that had historically been a leadership position. So we reviewed that position, and we made the determination that actually, given our current needs, we needed to have more of a focus on the analytical portion of the role as opposed to the leadership portion or the management portion of the role. So we did meet with CUPE, and we made the decision to transfer that into a bargaining unit position. The next step in that process is to make the decision around what the job rate would be. And so we went through the typical CUPE job evaluation tool, and it determined the job rate would be within band 10, which is the highest band, which ranges from $27.97 up to $34.94. The next step from there was we looked at what our colleague organizations are paying for this particular position, and what we found was that the range in salaries was substantially higher, and it ranged from $41.58 to $51.98 per hour. And in order to be competitive in our recruitment process, what we're requesting is to move this position to an out-of-schedule rate for compensation and to position it within the 50th percentile so that it's at $43.83 per hour.
Thank you, Susan. Members? Mr. Height?
Thank you, Mr. Chair. Through you to Susan. You mentioned that the CUPE job evaluation tool sets the rate at $27 to $35 an hour, and yet you're looking for $43 per hour, and they lose the management responsibility?
Through you, Mr. Chair, to Councillor Height. Yes. And in fact, given that two things factor into that, the CUPE job evaluation tool, what we've learned and what we've experienced is that it's typically not as sensitive as what one might hope when it comes to positions that have a high level of that knowledge capital. So this is a position that requires the individual to have, at a minimum, a master's degree in preparation, and to carry that analytical expertise to be able to conduct some of the evaluations that are required for our health unit. And so therefore, we do need to be competitive with what the market is bearing for this particular position, which would be the rate that is stated there. I do want to highlight that even with the proposed higher rate, this will represent a savings of about $15,000 a year to the health unit from the position or from the perspective of salary plus the portion that would be benefits. So it's a substantial savings.
So now I'm confused. There's a savings, yet you're raising the rate.
So through you, Mr. Chair, we're not raising the rate. This is actually a decrease in rate compared to what the previous management position of epidemiologist was being paid, because that position was being paid at a rate of, it was about $52 an hour. So
And how long was that position been vacant?
It's been vacant since the early part of February. And certainly it has not been without cost to other members of our staff who are bearing the brunt of having that vacancy because the work doesn't go away.
So with the CUPE job evaluation tool rate of $35 an hour, you don't feel that you would get any applicants?
That is correct.
Okay, thank you.
Thank you. Further questions? Mr. Sonnenberg has moved, Mr. Wells has seconded the staff report 17-05 be received as information, and that the wage for the epidemiologist position be an out-of-schedule rate of $43.83 per hour, less $1 for the first 6 months of probationary employment. Discussion on that resolution. I'll call the question. Those in favor? Those opposed? That is carried. Thank you. Page 40, Susan Taylor will give us the next report. This is a memo we received from her. This is the modernized Ontario Public Health Standards, the implementation of this. Susan, please.
Thank you, Mr. Chair. So we wanted to pause this afternoon and give you a little bit of an overview of our current landscape in public health. Sorry. So what we're seeing in public health at this time is there are actually three converging pieces of information that are of importance to us. The first is the Public Health Work Stream, and that's part of the Patients First Act. So as you may know or you may recall, just before Christmas of 2016, the Patients First Act became law. And as the province of Ontario is moving forward with the implementation of that, then there's a role within it for public health. And that's quite new for public health to be included within that array of service provision for health care. The second is there's a public health expert panel. And this expert panel has been called. It started in January of 2017, and it's intending to give its report to the Minister of Health in May of this year. And it will be looking at how is public health best organized into an integrated system. So thinking of those two components, so Patients First looks at how does public health fit within the system, and then the second is looking at within that system, how do we organize public health? And then the third component is the standards modernization. So that's looking at what are the services and programs that we require within public health and what should we be delivering. So this presentation is focusing on all three components of it, but the most pressing one for us is the standards modernization. So as I mentioned, as we move forward with Patients First and public health, what we'll be looking at is the formalization of relationships between public health units and the local health integration networks. So that will impact on how do we interface with the LHINs and how do we work with them. So the position of epidemiologist, for example, that we've just spoken about, will be really integral in this, because one of the key things we'll be doing is making that assessment of our current community's needs within the Haldeman and Norfolk counties, and how do those how are those reflected in the services that we provide, both within public health and within our healthcare services more broadly. One of the things that's really quite interesting is that public health does a very unique role in bridging that municipal, social, education, and health sectors with that focus on social determinants of health. So within Patients First, and I won't go into detail here, there have been a number of work streams that are part of that. So one is looking at how do we enhance equity across our health services so that it doesn't matter where you live or what group you might belong to, that you have access to the same services that will meet your needs. The second is around primary care and how is primary care organized across the province, likewise, so that if you have somebody who lives in downtown Toronto or in North Bay or Thunder Bay or Haldeman County, that they have access to those primary care services. The area that's currently under development with the LHINs is that organization of community home and community care services. So currently the LHINs are working with the community care access centers to have that integration take place with a target of May for that integration to be occurring. Public health will be working on that as well. And then finally, it is looking at how do we interface with our Indigenous populations and what is the role of our provincial organizations to be supporting. In terms of the expert panel is being chaired by Dr. David Williams, who's our Ontario's Chief Medical Officer of Health, and the executive sponsor is Roselle Martineau, who's the Assistant Deputy Minister with the Ministry of Health and Long-Term Care. The expert panel is intending to give its recommendations to the Minister of Health in May of this year, and it will be looking at that integration of population and public health into our health system, and how do we deepen those partnerships with the LHIN and with health boards of health. And then finally, what is the public health capacity and ability to deliver within a transformed healthcare system. And then finally, the standards of modernization. So the standards of modernization were released in a draft form in February of 2017, and the intention is that they will be formally released in May of 2017, and will be fully implemented by January of 2018. So that is in fact only 8 short months away, or 9 short months away. So we will be working very busily in the coming months to look at how do we align our services and how do we align our structures to be able to deliver on these particular programs as they come into play. A couple of things that I did want to highlight to the board this afternoon that are quite different from our previous standards. So the previous standards were released in 2008, and they were adapted and updated on a regular basis, but this has been the first major overhaul since 2008. One thing that's quite different is it is that balance between standardization and variability or variation. So it looks at what are the things that need to be the same across the province, so that would be things like our vaccination policies and protocols, and what are the things that might be different based on particular areas and particular geographies and communities. So it will be that variability that we're really interested in. How do we make decisions based on our local needs here in Haldimand and Norfolk counties? In terms of the actual side-by-side comparison of standards, our staff are currently working through this as we speak to look at how are they different, what are the things that we're currently providing that perhaps will stop, what are the things that we are currently not providing that we might need to put into place or we will need to put into place, and what are the things that won't change substantially. So there are some aspects of the standards that don't change substantially, there are some new things, and there are some things that will cease. One of the things that we did want to just highlight is certainly from the perspective of health equity, and that is a topic of interest across the healthcare system and across public health. It is that look at how do we ensure that we are providing equitable access to care and to services. So from our local perspective, where this might come into play would be looking at how do we enhance our partnerships with our colleagues through our First Nations communities at Six Nations and the New Credit. Looking at effective public health practice, one of the things here that we wanted to highlight for you is that starting in 2018, part of our accountability will be to be releasing a public report on what our plan is, our operational plan is for the coming year. So that's not dissimilar to what the LHINs currently do, where if you go to their website, you'll see, for example, what their operational plan looks like, and to have that associated with our budget. In the school health team, one thing that's quite different is that we will be required to be providing some vision health screening. So we're not quite sure what that will look like at this time, but we are looking at what will be the requirements and how might we put that in place within our communities. So those are some of the highlights. May is a big month, so May is when the standards are released. May is when the advice to the minister from the expert panel will be going forward. And then finally, May is when we'll be starting to think about how does this come together with Patients First. Okay. So we did have some questions, and certainly if we have some opportunity for discussion, we will be going, and there is a contingent. We have 2 members from our Board of Health and 2 members from our advisory committee who are attending next week on April the 3rd. There is an opportunity for people to talk about what are the implications from the perspective of implementation. The standards are not up for discussion at this point. The ministry has very clearly stated that the standards are what they are, but that our discussion, our consultation next week will be around how do we implement and what might be some of the implementation challenges. And then certainly looking at providing a formal written response to the standards and the implementation challenges. Actually, the presentation says April 3rd is when that's due, but that timeline has been extended by a couple of weeks, so we'll be working towards that. And we do feel quite strongly that our unit is actually in a good position to deliver on the new standards. Our structure is, for the most part, aligned. There may need to be some minor tweaks to fulfill that, and we're currently working through that. But I think we're sitting in a relatively good place. Okay, thank you.
Thank you. Any questions from Ms. Taylor? Mr. Height?
Mr. Chair, would you be able to jump back to, say, the second slide? Right back to the beginning. Oh, forward one.
Yes.
Right there, number 3, transfer responsibility for service management and delivery of home and community care from CCACs to LHINs. Aren't the CCACs private?
No.
They're not? Or
No.
they?
No, so...
What is that?
Yeah.
Like, how do you see that moving together?
Certainly. So through you, Mr. Chair, to Councillor Height. So what's happened is the community care access centres are fully funded by the provincial government. LHINs are also part of our provincial structure. So what's happened is CCACs, in their provision of home and community care services, they contract to various service providers, but they have an infrastructure that organizes that delivery of care. And what's happening is that there is that convergence between the CCACs and the LHINs. And so the LHINs historically had a role of planning and an organization of services, but not of delivery of services. So now as those two organizations are coming together, so they are merging to become one, and they will become a service delivery organization. So it will also align with number 2 on there, which is the connection to primary care. And it's not that primary care will become part of the LHINs by any stretch, but what it is that the LHINs will be accessing and leveraging the resources in primary care to say, how do we connect? Say, for example, a case manager from CCAC, and they may be sitting within a family health team and organizing care from there. So it is actually, I believe, certainly an opportunity for greater efficiency, but it's also an opportunity for better patient care and more coordinated patient care.
Do you feel this merger would help the seniors receive better care or get better care?
Yeah, so through you, Mr. Chair, yes, I do.
Okay, great, thank you.
Mr. Oliver?
Thank you, Mr. Chairman. Susan, my question is on the same page, or the same slide rather, and it's point number 5, and this is with respect to a more inclusive Indigenous voice through a stronger role in system planning. I understand what that's all about. I guess the concern that I would have, or the comment that I would make, is the last 2 lines in that bullet, and that is enabling culturally appropriate care and incorporating traditional approaches to healing and wellness. So my question to you, and perhaps a question that we should raise at this consultation, does that imply then that the province will be adding staff or required to somehow cover costs of incorporating traditional healing methods that the First Nations might have utilized in decades gone past and wish to do now? I mean, I'm just concerned about potential significant cost increases across the whole health sector in Ontario and within our own health unit, as an example. If new staff, new types of positions with new types of skills are going to be required for a small segment of the whole population in the region.
Certainly.
So a comment on that, or am I overly concerned about it based on this point?
For sure. So through you, Mr. Chair, so it's my understanding that the Patients First Act is truly all about partnerships. And so a good example for this might be that actually today we hosted a prenatal networking day in Caledonia. And as part of that, we invited our partners from midwives, from primary care physicians, from prenatal classes, those sorts of things. But we also invited our partners from First Nations. So that's an example where this is about how do you build a community of services and how do you ensure that we do provide those opportunities to involve our partners from First Nations. I'm not seeing this, but that's my opinion at this point, as being something that will change a budget line per se, but it will change our practice because one of the first things that we'll want to do is be sure that we are reaching out and we are inclusive of our entire community, regardless of where they happen to live.
Thank you very much for that. And I'm encouraged, I guess, in that you are, and I'm sure all of our staff are sensitive to the potential financial implications of any change. And this would be one of them. Thank you.
Anything further from members? By Mr. Geisen, seconded by Mr. Columbus at the presentation, respecting the implementation of modernized Ontario Public Health Standards, be received as information. Discussion. Those in favor? Carried. Over to page 42, HS 1704. This is concerning the 2017 budget reductions for our health unit. Susan?
Thank you, Mr. Chair. So back when we went through the budget deliberations in the latter part of January, early February, the direction to the health unit was to reduce the levy impact by $143,420. We did want to come back to the Board of Health this afternoon to do two things. One was to certainly to respond to how we intend to make those cuts to our budget, and to say that we're very pleased to say that we've been able to do that, and without impacting services. So we want to also acknowledge that our staff have been tremendously supportive as we've gone through this process, and they've made some very good suggestions that we've been able to carry forward and to reflect in this particular memo. So in terms of what we've done for the reduction, we also wanted to, on the second page of that memo, to highlight that there are some unique aspects to our budget that we needed to consider when we were doing this. So one is thinking about the fact that we are a shared cost model. And so for a portion of our budget, it comes from the Ministry of Health or it comes from the Ministry of Children and Youth Services. And so to decrease some spending wouldn't actually have any impact at all on the levy. It would only involve sending money back to the ministry. So we needed to be very careful about what aspects of the budget we were addressing and we were reflecting in our reductions. The second component to that is that in most cases there's not the ability to transfer funds within our budget lines. So for example, if we've got some money that's coming for a particular program or service and it's underspent, and there's another program that is overspent from the perspective, not overspent, but it's higher than that capped amount, we can't simply transfer from one to another. They are looked at individually and independently. So again, we needed to look at where could we target the reductions so that we could achieve the levy impact without reducing services. So you'll see on the bottom of the second page that the way we were able to do that was really quite multifaceted. The first was looking at conversion of that vacant management position, so that was that epidemiology position, to a bargaining unit position, and the subsequent reduction in salary and benefits. The second thing that we did was we looked at our training budgets and we looked at our training requirements, and we made some decisions about our ability to still meet those requirements with a reduced budget and how might we do that. And one way that we felt we would be able to do that quite nicely was by providing some in-house training that would then decrease the cost for participation per person, and it also reduces the travel and registration fees. The second was about reducing office supplies and printing supplies. So we are encouraging our staff to move more to paperless meetings, move more to paperless memos,